Hello, I am Dr. Hak CHANG from Department of Plastic and Reconstructive Surgery, Seoul National University Hospital, Seoul, Korea. Today, I'm going to talk about up-to-date of facial nerve reconstruction. Facial palsy inflicts significant morbidity, and treatment aims to address functional, aesthetic, and psychological aspects. The facial nerve is responsible for providing the facial tone and movement necessary for ocular protection, nasal airflow, articulation of speech, and oral continence. Furthermore, psychosocial functioning of the individual is greatly influenced by the activity of the mimetic musculature. The causes of facial palsy are numerous and have been classified into congenital and acquired. The most common congenital facial nerve palsy is from birth injury, and most patients recover within a month. Idiopathic isolated palsy of the mandibular division is a typical presentation, but the true instance is hard to define. Syndromic facial palsy is infrequent, but is most commonly part of hemifacial microsomia. Möbius syndrome is a rare congenital form of cranial nerve palsy. We should concern for neoplastic cause if unilateral facial weakness, slowly increasing for more than 3 weeks, or abrupt onset with no return of function in 6 months are observed. Most common cause is Bell's palsy. The instance is reported to be 1 in 5,000. 3/4 of the patients return to normal function, but a significant portion suffer sequelae such as weakness, hemifacial spasm, contracture, or synkinesis. Early treatment is centered on the use of corticosteroids and antiviral therapy to speed recovery and minimize residual deficit. The efficacy of acyclovir, however, has been debated, and level 1 evidence shows no benefit over corticosteroid therapy alone. 3 weeks period observation is acceptable before undergoing an extensive diagnostic workup. A multidisciplinary approach is key to achieving good outcomes for patients. A structured history and clinical examination of the patient allows for accurate treatment planning. Once etiology is established, the next step is to ascertain the time elapsed since onset, as this will directly affect the surgical strategy employed. Clinical examination is performed from the brow down. The absence of iritis and the degree of the brow ptosis are examined. The patient is asked to raise their eyebrows, close their eyes, and show their teeth. Bell's phenomenon is also documented. Nasal valve collapse is examined using Cottle test. The mouth is examined at rest, with the amount of commissure droop, and deviation of the philtrum to the contralateral side is measured. The excursion of the commissure is also quantified, and degree of tooth show in the shape of the smile are noted. Facial synkinesis is one of the most distressing consequences of long-standing facial paralysis. Synkinesis refers to the abnormal involuntary facial movements that are caused with voluntary movement of different facial muscle groups. The pathophysiologic basis of facial synkinesis is likely multifactorial, although the predominant mechanism appears to be aberrant regeneration of facial nerve fibers to the facial muscle groups after facial nerve injury. Symptoms include abnormal muscle contractions of eye, mouth, mid-face and neck, tightness, rigidity, and hypolacrimation. Synkinesis can cause functional limitation with activities such as eating, drinking, smiling, and may even lead to social isolation. Synkinesis is diagnosed by history and physical examination. It typically does not require an imaging study to diagnose. Facial rehabilitation specialists guide patients through targeted exercises and design an individualized treatment regimen. synkinesis does not respond to facial muscular retraining may benefit from targeted injection of botulinum toxin to ease unwanted facial muscle spasm. The buttocks mechanism of action in the lacrimal gland is the presynaptic blockade of the acetylcholine release at cholinergic nerve endings, thereby reducing the stimulus on the gland activity. This mechanism is similar to that observed in the treatment of the hydrosis of sweat glands and the sialorrhea of salivary glands. For some patients, the temporary relief provided by botulinum toxin can guide their surgeon towards surgical procedure for more long-standing benefits. Treatment plan is individualized and it is based on the pattern of the facial movements as well as the response to the botulinum toxin injections. The House-Bregman grading scale, developed in 1983, is most frequently used tool to assess degree of facial weakness. This scale has documented pitfalls, including that it does not fully represent facial function, lacks sensitivity to subtle differences in severity of the weakness, and has documented high inter-observer variability. The Yanagihara facial nerve grading system was developed in Japan as a representative regional scale, which was standardized in Japan and in some other countries for grading facial function. The Yanagihara system measured 10 separate aspects of different facial functions. Each function is scored 0, complete palsy, 2, partial palsy, or 4, nearly normal, giving a maximum score of 40. The score provides information on the grade of facial nerve dysfunction. The Sunnybrook facial grading system is a comprehensive scale for the evaluation of the facial paralysis patients. It is relatively easy and quick. There is an evaluative difference between the weighted regional Sunnybrook and the gross House-Bregman systems. However, these methods have limitation in the precise assessment because of subjectivity in diagnosis. Depending on the etiology, imaging may be required to rule out malignant pathology or recurrence following tumor resection. Videography or a series of standardized photographs is taken for the medical record. Electrophysiological investigations are generally used to provide prognostic information in patients with partial or acute palsy, but these tests are of little value in patients with an established paralysis. Degeneration greater than 90% in electroneurography or threshold difference greater than 3 mA in nerve excitability test is associated with poor prognosis. Side-to-side amplitude comparison and electromyography are the two most valuable electrophysiologic methods of asserting facial nerve function. In addition, the blink reflex is a polysynaptic reflex response of the orbicularis oculi muscle elicited by electrostimulation of the supraorbital nerve is mediated by the afferent trigeminal nerve, the brainstem, and the efferent facial nerve. The blink reflex test can be used to evaluate the function of the involved nerves. The persistence or early return of an absent R1 component of the blink reflex may quantitatively suggest a satisfactory function outcome in facial paralysis. There are several modalities for the treatment of the facial nerve palsy, such as acupuncture therapy, massage, and facial rehabilitation. Today, facial reanimation is the gold standard for the facial nerve palsy. The aim facial palsy reconstruction is to treat functional issues, re-establish symmetry at rest, and restore dynamic spontaneous movement. Numerous surgical options exist for the treatment of the facial paralysis. The key to successful outcomes is to establish the achievable treatment goals based on the patient's chief concerns in decision-making process. Surgical plan is determined by the key factors: whether the injury is partial or complete, the presence of a proximal nerve stump, and the time elapsed since injury. First, ocular protection is the most important issue to be addressed in the treatment of the facial nerve palsy. The immediate concern is to preserve corneal integrity by using lubrication and lid taping. Leg ophthalmos is the most common symptom secondary to facial palsy. This is consequence of the loss of antagonistic muscles with a levator function for the upper eyelid. As a result, dryness, corneal keratitis, and continuous conjunctival irritation occur. The upper lid can be loaded with a gold weight. This provides good symptomatic relief from corneal exposure, but is associated with high extrusion rates after 5 years. Concha cartilage is useful alternative to gold weight. Ectropion is secondary to loss of orbicular tone and compounded by ligamentous laxity in older individuals. For this, canthal tensioning procedure such as canthopexy, canthoplasty, or fascial sling is required. In partial facial nerve palsy, the residual function in the nerve can be augmented by introducing an additional source of innervation in the form of cross-face nerve graft or nerve transfer. The end-to-side nerve coaptation is preferred to avoid reducing any residual function on that side. An alternative approach would be to minimize asymmetry by reducing function on the unaffected side by using botulinum toxin. Transection of facial nerve is suitable for direct nerve repair if detected early before retraction of the nerve ends has occurred. The use of nerve stimulator minimizes the chance of incorrectly matching the nerve ends. If there is tension on the direct coaptation, nerve grafting is mandatory, as tension has a negative impact on neural sprouting. As a donor nerve, the sural nerve offers a two-team approach, has an excellent size match to the facial nerve, and has a minimal donor morbidity. If a proximal nerve stump is unavailable, then an alternative source of innervation needed to be considered. In complete injuries, a cross-face nerve graft or cranial nerve transfer will be required if there is no proximal nerve stump. Facial nerve stump anastomosis to hypoglossal, glossopharyngeal, accessory, or phrenic nerves. Hypoglossal nerve transfer is one of the most common procedures. This is best for immediate reconstruction of proximal facial nerve during tumor extirpation. It provides excellent tone and normal appearance at rest. However, this may lead ipsilateral atrophy of the tongue musculature with effects on speech and swallowing. Babysitter procedure may be used as a temporizing measure to provide faster re-innervation to preserve the musculature and possibly the denervated stump while the axons grow across the cross-face nerve graft. Recently, the use of motor nerve to the masseter has increasingly performed. The benefit of using massetering nerve include a single-stage procedure, preservation of the contralateral facial nerve, and a greater axonal load can be delivered to the muscle. A degree of cortical plasticity is thought to develop following a program of biofeedback exercises. In contrast, use of cross-face nerve graft does not require such cortical plasticity and may be more appropriate in some patients. From now on, I'll present the surgical options in case with absence of mimetic muscles after long-standing atrophy with no potential for useful function. Browpexy effectively treats impingement of superior visual field. Direct brow lift, balloon slice of skin excised just above the brow, is the most basic and effective form. In the region of mid-face and mouth, static and dynamic procedures are routinely used. Static procedures address the symmetry of the face at rest and are suitable for older patients. Fascia lata and palmaris longus tendon slings have been widely used to elevate the cheek, support the lower eyelid, create the nasolabial fold, and draw the nasal ala laterally to open the external nasal valve. To avoid donor morbidity, Gore-Tex slings have been used, but with a high rate of complications such as infection. Subperiosteal facelifts are more effective and aim to raise the origin of the zygomatics and the levator muscles of the lip. Regional muscle transfers have been described to dynamize the face by utilizing the functioning trigeminal nerve on the paralyzed side. Local muscle flap may enable dynamic movement of the oral commissure. The two muscles that can be used for this purpose are the masseter and temporalis. Temporalis muscle flap is quick, simple, cost-effective, and especially useful in old age patients. This actions during mouth clenching and provides excellent aesthetic and functional results. There are numerous modifications of the temporalis muscle flap to animate the oral commissure or the eyelid. In 1997, Labe first described temporalis myoplasty technique, which separates the temporalis muscle from the temporal fossa and allows a lengthening by a redistribution of muscular fibers to the detriment of the posterior third for lip animation. Recently, minimally invasive temporalis tendon transfer only via intraoral approach was reported. Currently, temporalis myoplasty is regarded as the most commonly used non-free flap muscle transfer option, considered feasible with good outcome. Although masseter transfer has been attempted, it was associated with poor results or considered to be technically challenging. Traditionally, the masseter muscle transposition flap requires detaching the muscle insertion at the mandibular angle and reattaching it to the oral commissure. The limitation of this technique is that the vector of the pull is too horizontal and it does not simulate the natural smile. The masseter muscle is detached from both its origin and insertion and transferred to a new position to imitate the function of the native zygomatics major muscle. The availability of the viable facial muscle is an important issue in facial reanimation. Facial muscle may remain viable up to 12 to 24 months, but after this time is deemed irreversibly atrophic. When there is no viable musculature, the muscle may be important in the form of the free muscle transfer. Gracilis muscle and the latissimus dorsi is one of the most commonly used choices. Gracilis muscle has constant anatomy and is a simple dissection and is of intermediate bulk, but with minimal donor deficit and hidden scar. A two-team approach is available. A large latissimus dorsi can split into two independently innervated territories. We reported the outcome of 13 patients who underwent interfascicular nerve splitting and dual innervation technique in JPRAS journal this year. Faster and more powerful reinnervation through the massetering nerve, as well as spontaneous smile through the contralateral facial nerve can be achieved with this technique. Interfascicular nerve splitting is not technically difficult, taking approximately 15 minutes under microscopy or high magnified surgical loops. This technique could induce greater shoulder function improvement compared to other studies regarding donor site morbidity of muscle-sparing latissimus dorsi flap or TDAF flap. Our patient showed the same level of the recovery within 12 months compared to at least 3 years of recovery in other studies. Two-stage procedure has following advantage. Above all, possible confirmation of reinnervation before nerve coaptation is the biggest advantage. However, it usually takes 10 to 12 months to confirm the presence of tinal sign favoring axonal regeneration. One-stage procedure is introduced to overcome disadvantage of two-stage method. Paralysis of mandibular and cervical divisions can lead to unopposed action of the lip elevators. As a result, a symmetric smile that is commonly noted by patients. The approach to this is augment the activity of the affected side or reduce motion in the normal side. A number of methods have been proposed to re-establish the lip depressor mechanism, including mini-hypoglossal transfer, anterior belly of digastric transfer, and platysma transfer. Because these procedures leave considerable scar on the neck, some prefer the approach of weakening of the contralateral sides using botulinum toxin. There are various techniques for outcome evaluation following facial reanimation surgery with free muscle flap. Consensus has yet to be reached for postoperative outcome evaluation. Turkish facial grading system evaluates facial symmetry at rest and quality of smile. It was created in 1997 to evaluate surgical outcomes following free muscle transfer reanimation procedures. Its shortcomings include that it does not evaluate recovery of essential facial functions, nor does it assess psychosocial recovery. Numerous newer tools have been reported in the literature. These include Emotrix and clinical graded electronic facial paralysis assessment (eFace). Emotrix is a facial measurement software that utilizes machine learning technology for facial landmark identification and evaluation of facial movement. Another potentially significant tool, eFace, overcomes the limitation of other clinician-based tools in that it dependently analyzes static, dynamic, and kinetic facial feature. In conclusion, few authors have reported direct comparisons between different surgical methods because of lack of widely accepted grading tool. There is one study comparing neural versus muscle reconstruction for ocular sphincter reanimation. The results showed better results in the neural reconstruction where viable facial muscle was present. Another study showed that outcomes from free muscle transfer are recognized as providing results superior to cranial lobe transfer or local muscle transposition. Most importantly, it is essential to match the patient's wishes to the reconstructive technique to achieve patient satisfaction. Thank you for your attention. I hope all of you understand all fields of facial lobe reconstruction. Thank you very much.